This presentation outlines case study 3. John, a 44-year-old electrician with left supraspinatus tendinopathy and secondary right lateral epicondylitis. His shoulder pain began 6 months ago, confirmed via ultrasound, and is aggravated by repetitive overhead work typical of his trade. He reports a dull ache over the shoulder radiating to the mid-deltoid and occasional right lateral elbow pain during gripping or when using a screwdriver. Despite modifying activities, his symptoms persist due to job demands. John's goals are to reduce pain, improve shoulder strength and endurance, and return to full work capacity without limitation. John presented with left supraspinatus tendinopathy, a degenerative condition of the rotator cuff tendon caused by repetitive overhead activity and excessive mechanical loading. This condition is characterized by microtears and collagen disorganization within the tendon, leading to reduced tensile strength and pain during movement. The supraspinatus tendon passes beneath the acromion, making it highly susceptible to subacromial impingement, particularly during abduction during 60 to 120 degrees. Over time, poor scapular control, rotator cuff weakness, and glenohumeral instability can alter normal biomechanics, reducing the subacromial space and increasing compressive forces on the tendon. This results in a painful arc, weakness during resisted abduction or external rotation, and loss of internal rotation. Functionally, this affects John's ability to perform overhead movements such as reaching, lifting, and manual work tasks. At his job, repetitive arm elevation and sustained postures above shoulder height likely contributed to the onset and persistence of his symptoms. His condition limits his ability to complete overhead and reaching activities both at work and in daily life, including dressing, carrying objects, and lifting heavy items to or from high surfaces. John also presented with right lateral epicondylitis, commonly referred to as tennis elbow. This condition is a degenerative tendinopathy of the common extensor tendon, most often involving the extensor carpi radialis brevis. It develops through repetitive wrist extension and gripping, which cause microtears and collagen disruption within the tendon near its origin at the lateral epicondyle. The resulting tissue degeneration and failed healing response lead to pain during gripping, lifting, and resisted wrist extension, as well as reduced forearm strength and endurance. For John, frequent use of hand tools, screwdrivers, and repetitive gripping tasks in his work environment likely overloaded the extensor tendons. Functionally, this reduces his ability to perform fine motor and manual labor tasks, such as handling tools, lifting objects, or even carrying groceries, as gripping activities trigger pain and weakness. Orthopedic testing revealed positive empty can, full can, and NIAS tests indicating supraspinatus tendinopathy. Pain and weakness during abduction suggested tendon inflammation or degeneration, while pain reproduced in NIAS test supports impingement-related pathology and scapular dyskinesis. Positive Mills and Cozen's tests on the right arm confirm lateral epicondylitis with pain over the lateral epicondyle due to extensor tendon tension, particularly the extensor carpi radialis brevis. Range of motion tests showed reduced left shoulder internal rotation and painful abduction between 90 and 120 degrees, consistent with the supraspinatus painful arc and posterior capsule tightness. Limited external rotation of 45 degrees on the left and 50 degrees on the right indicates restricted rotator cuff mobility, while mild restriction in right wrist flexion with 25 degrees aligns with the lateral epicondylitis. Functionally, John demonstrated reduced upward scapular rotation and left scapular winging, indicating scapular dyskinesis and supraspinatus overload. His left-sided single-arm row load tolerance of 20 kg versus 25 kg on his right highlights posterior chain weakness and poor scapular stability. Overall, these findings confirm rotator cuff weakness, scapular dysfunction, and compensatory forearm strain from altered upper limb mechanics. In regard to the client John, a short-term goal is to reduce pain, shoulder and elbow pain to a manageable level, around an RPE2. A mid-term goal is for him to regain full functionality and confidence when performing light tasks overhead. Finally, a long-term goal is that he can perform all work duties comfortably and without fear of re-injury or aggravation. As a practitioner, the short-term goals for John are to reduce shoulder pain to an RPE2, restore shoulder abduction range of motion to 170 degrees, and internal rotation to 35 to 40 degrees, along with improving scapular control to reduce visible winging during low load movements. These goals aim to restore comfort and movement efficiency during basic daily and occupational tasks. Medium-term goals are to increase shoulder abduction and external rotation strength to at least 4 or over out of 5 manual muscle test. Maintain scapular upward rotation and retraction during dynamic loading tasks, and reduce elbow discomfort to RPE 1 while restoring full grip strength. This phase will prepare John for higher load, functional movements, and reintroduction to more demanding work-related activities. Long-term goals are to achieve 90 to 100% limb symmetry in both shoulder and forearm strength, restore full overhead range of motion without pain or compensatory movements, and develop occupational endurance to tolerate repetitive overhead and gripping tasks without aggravation. The warm-up aims to increase circulation and shoulder mobility while avoiding excessive supraspinatus activation. Dale-assisted internal/external rotations and pendulum swings are performed within a pain-free range to lubricate the joint and prepare the rotator cuff for loading. Gentle supported motion helps prevent stiffness and maintain glenohumeral mobility, aligning with rotator cuff rehabilitation guidelines. Together with crossbody and sleeper stretches, these activities enhance flexibility and tolerance for subsequent strengthening work. Isometric external rotation with a towel under the elbow activates the infraspinatus while minimizing supraspinatus compression beneath the acromion, promoting proper shoulder kinematics. Evidence supports that isometrics reduce pain and enhance tendon load capacity without exacerbating symptoms. Similarly, side-lying dumbbell external rotation targets the posterior cuff to improve dynamic control. Scapular retractions strengthen the middle traps and rhomboids, improving retraction and stability during elevation. Serratus anterior wall slides encourage upward rotation and posterior tilt, which are key for restoring efficient mechanics and preventing additional complications. These exercises address the link between poor scapular control and forearm overload, as inadequate shoulder stabilization can increase wrist extensor strain, contributing to tennis elbow. All movements are performed slowly and deliberately to reinforce motor control and minimize compensations. To specifically address the right lateral elbow, isometric wrist extension maintains forearm strength whilst reducing pain. Once tolerated, eccentric wrist extensions with a light dumbbell are introduced to promote tendon remodeling and collagen alignment. Eccentric loading enhances tendon tensile strength and reduces pain in chronic tendinopathy. These are performed with a 3-second eccentric to maximize time under tension and drive adaptation. The session concludes with crossbody shoulder forearm flexor and extensor stretches and low amplitude pendulum movements to maintain flexibility and support recovery. Post-exercise stretching assists circulation, reduces tightness, and prevents adaptive shortening that limits mobility. Safety considerations include monitoring for pain above 3 out of 10, working within pain-free ranges, and avoiding end-range overhead or gripping movements early in rehabilitation. Exercises may be regressed by reducing resistance or end-range motion. To progress into the intermediate stage, John must demonstrate full shoulder range of motion, including abduction to 170 degrees and internal rotation to 40 degrees, all while maintaining proper scapular control without winging or compensations and an RPE of 2 or less. As the program will progress to light resistance and dynamic loading, this is essential. Palpation of the scapular spine and inferior angle will confirm correct mechanics during these movements. The progression criteria for this include achieving a manual muscle test of 4 out of 5 for abduction and external rotation, shoulder pain of RPE or 2 or less, and an RPE of 1 for elbow discomfort. Meeting these benchmarks indicates adequate strength, control, and tendon tolerance for progressing to more functional load-bearing exercises. To advance from the intermediate to the advanced stage, John must perform all strengthening and stability exercises with proper scapular alignment and no compensation. The advanced phase will include higher load, work-specific tasks such as repetitive overhead lifting and gripping. Progression requires at least 90% limb symmetry and strength, which will be measured with handheld dynamometry. Along with this, John will need to be pain-free in the overhead range with manual muscle test scores of 5 out of 5. John must also maintain controlled scapular motion and endurance during dynamic multi-plane movements. Achieving these outcomes will confirm restored strength, stability, and neuromuscular control, allowing John to safely and comfortably complete his work.